Hello, this is Professor Land with Nursing 421. This is Nursing 421's Exam 4 content review for topics 11 through 15. The attachment to this presentation is actually the Word document that is your blueprint for Exam 4. And if you can pull that up, we will be going through that Exam 4 blueprint very succinctly. We're going to hit each of the topics and each of the objectives for each of those topics. So the first one is, the first module is actually talking about evidence-based practice. And so the very first objective for the evidence-based practice piece says that a student needs to be able to analyze the evidence-based practice concepts to determine and employ best nursing clinical practice. Actually, what that means is you need to be able to analyze the concept, and then you need to determine how and when to use this best practice in your nursing practice. How do you know that the evidence is valid and reliable, that the study is worth paying attention to? Are the authors experts? Is the sample size large enough that you can actually generalize it to other populations? What is the actual purpose of this study, and does it make a difference? What's the purposes of this all happening now anyway, compared to us not worrying about evidence in the past? Those are the things that you need to be able to discuss to meet this first objective. The one method that I need you to really remember is the ABCDE method. Just like with the airway breathing circulation method of determining urgent life-saving prevention, analyzing evidence is done in the same fashion. We have to analyze it. We have to, make sure that it has reliable information, that, it's not the first author, it's not the author's first publication, so we really don't know whether they're actually having good results or if this is just a fluke event. So those are the things that you need to be able to do for the very first objective. The second objective is talking about demonstrate a spirit of inquiry regarding the rationale of traditional approaches to client care, processes, and decision making. So if you look at that in a different way, why do we do the things just because that's the way we've done them always before? Just because we've done them always that way doesn't make it right, does it? So how do we approach each other and help shift the thinking that we currently see out in the practice world right now? One of the ways is to always ask questions. In my class, I always talk about the nurse is actually a CSI. They're a crime scene investigator, and you can portray your patient, whatever's happening to them, that is the crime. And you need to investigate it by doing your forensics. What's your lab work? What's your medical history, your background, all of that. So if you actually portray it in that fashion, the best way is to always ask more questions. Always ask more questions. It is the best way to be informed, and then that enables us to actually do an excellent job of educating the public or our patient and family so that they then can make an appropriate and safe decision about the care that they're going to receive. Okay? We'll go into that a little bit in more detail in Objective 4, but just suffice it, this piece is just the inquiry piece is where you need to always ask questions. Why do we do it this way? What's the evidence out there? Is there anything that's new evidence? And just having that questioning effect is always going to help us stay on the positive side of patient outcomes. And that is our actual goal, and that is our purpose as nurses, is to improve patient outcomes. So the next objective, Objective 3, talks about examine the role of scientific inquiry as it applies to concepts and practices of continuous improvement in nursing clinical practice. So essentially, how do you evaluate the patient care that's delivered based on whatever that current evidence is? How do you evaluate that? How do you know that it's working or not working, or that we have to adapt it maybe to make it work better? Why would we be worried about, evaluating it and making it better? Why would we be worried about that? Well, remember, our ultimate goal is to improve patient outcomes. Well, if we're going to be continuously improving, we have to be continuously evaluating to see what needs to be improved or how can we improve that. Again, that spirit of scientific inquiry helps us on a continuous basis improving things for our patients. Now, that being said, we are always improving our own selves when we are improving the outcomes for our patients as well. We have to keep that in mind. You have to remember that this actually helps us make things better for everybody, the entire community, the entire populace in America and the world. So the fourth objective says, please appraise optimal individual client care delivery options based upon current evidence, client values, cultural needs, and clinical expertise. Well, what that means is, how do you evaluate that patient care based on that most current evidence, okay? Kind of exactly what the last one said. Okay, but the next piece is, do we actually need to include the patient's values and cultural needs in this to make this work? And in class, it was discussed that yes, actually, since it's patient-centered care and the patient is at the center of our care, and they are actually the masters of their own personal bodies and what is done with it and what isn't done with it, then yes, we do need to include the patient, their values, and their cultural needs. So do we need to rely on our own personal clinical expertise as nurses when we are evaluating the care that our patients are getting? Why? Well, yes, we do. We have to remember that just because we have evidence and just because we've educated the patient does not mean that we can slack off and just let things go. We still have to stay within our comfort zones. We have to stay within our knowledge zones. Now, patients can make the decisions. Can we further educate based on changes in the patient status that we see? Can we update them based on changes in the status that we see? Yes, we can. I don't mean that you need to harp on them until they change their mind, but I do need you to be able to provide updates and allow them the opportunity to change their mind if they choose to do so. We can't force that. We should never try to force that, but we should give them the opportunity to see if they want to do that based on appropriate education. Just like with informed consent for any kind of invasive procedure that we do, we need to make sure that they're making informed decisions on what they do and don't want. They need to have informed information. They need to be informed to consent, yes or no, to the options. Okay? So the fifth objective says, demonstrate the ability to locate and utilize applicable evidence reports related to nursing clinical practice topics and guidelines. So how do you go about finding applicable and reliable evidence reports? And what about those that are related to clinical practice topics and nursing guidelines? Well, you've actually done this. You learned how to do this in your evidence-based practice course, and then you actually were able to implement some of that and utilize that information when you did your capstone project. The one thing that you may not know about is the clinical practice topics. You can find quite a bit of research in the Joanna Briggs database, which is one of the largest nursing research databases in the world. It is based in Sydney, Australia, and Joanna Briggs has the most up-to-date and the most complete database that we have for nursing in general for our world, actually. The other one that I would like for you to consider that you may not know about is the Nursing Guidelines Clearinghouse. If you were not provided that as a link to possibly review for your capstone, I'm sorry to hear about that, because it actually can help you narrow down what kind of topics you want to study, and promote. But so again, you know, you can use the GCU library, our database. There's also several other databases. Please keep in mind that now that you are graduating and you're moving to alumni status, you will always have access to the GCU library as an alumnus. And it is something that you will find that you will be using it. I do know that several of the organizations, especially Banner as one of them, have librarians that can help you with issues and research and stuff like that. Especially the regional one. Her name's Nancy, and she rocks. She's one of the best librarians for nursing or for healthcare I have ever met, and she's just a saving grace for nursing. So that's how you find it. You go to these reputable sites, these reputable databases, or to people of reliability, and have them help you reach the information that you need. Okay? You actually did it already when you did your capstone and when you did your evidence-based topics in your EVP class. So I'm not going to harp on that one very much, because you have already actually physically done it. I just wanted to give you those 3 resources that I want you to be aware of. Joanna Briggs, the GCU library, and then of course the Nursing Guideline Clearinghouse. Okay? Moving on to the next topic, the next module topic is safety, module 12. And so the very first objective for that one says that I need you to be able to summarize factors and safety design principles inherent to the concept of a culture of safety. Well, to be able to do that, you need to know what is a culture of safety. And it's just exactly what you think it is. It's a place where people keep each other safe, be that nurses keeping patients safe, nurses keeping nurses safe, executives keeping staff safe. It's the whole shebang, the whole shebang. Everybody is a partner in a culture of safety. Everybody participates, and they are all covering everybody. One part of a culture of safety is a healthy work environment. So not only physical safety, but we're also talking about mental safety and stress safety, as well as the physical piece. So we need to be able to report errors and discuss situations in a safe environment where we do not feel that we will have retaliation or retribution because we brought up a subject that someone was not happy to discuss or didn't want to have the discussions about. So that is where healthy work environments are going and where they've been going. And that's kind of what I mean when I talk about a culture of safety. It's not just keeping the patient safe. It's a safe environment in general for everybody. Second objective is that you should be able to illustrate examples of individual and then system factors which positively impact the culture of safety to result in improved patient outcomes. Well, that's just saying I need you to be able to give me some examples of individual factors that positively impact safety, resulting in improved patient outcomes, and then system factors that positively impact the safety resulting in improved client outcomes. So individual-wise might be something where we talk about you as the nurse that's assigned to that patient. You personally can illustrate examples of individual factors of positively impacting cultural safety, where you don't automatically restrain somebody just to try to keep them safe. You actually try to figure out what was the underlying cause of their confusion, disorientation, and agitation. Maybe they have to go to the bathroom. Maybe we actually try to figure it out. If it is a demential situation, like a sundown situation or something, then we have other tools and possibilities at our fingertips. Like maybe instead of tying somebody down, we can now use a sitter. All right, and so those are system-based pieces. But you as an individual have to initiate them. Okay? So those are system-based, but you as an individual have to implement them. But you as an individual, you are also trying to keep people safe by making sure that there's no liquid on the floor in the patient's room or even in the hallway. The dirty linens are not put on the floor where people can trip over them. They're actually put into the laundry hamper. Your patient that goes to the bathroom, you actually do not walk away. You actually stand there. Yes, you can crack the door just a little bit, close it a little bit, but you need to be able to hear your patient, especially if they need to call you or if there's something that goes wrong, you be able to understand that, hear that. One of the biggest problems with unsuccessful codes is where the patient got up, went to the bathroom, and they were assisted to the bathroom, the door was closed, and then whoever helped them walked away. And then when they didn't call, somebody went to check on them, and they couldn't get the door open because the actual patient had fallen in the floor off of the toilet in front of the door, so the door can't be removed. And then, of course, you have to call maintenance, and they have to take the door off the hinges. But by the time you get to the patient, you can no longer do heroic rescue because it's been too long. So based on individual decisions that we make, they will affect our patient's quality of care. And we not only do need to keep our patients safe, but we need to keep ourselves, our other staff members, and the family members as safe as we possibly can. So that's kind of what that means when we talk about that. So the next objective, objective 3, is where we're talking about you being able to examine the complexity and management of medical errors, those adverse events in regards to improved client safety. I do want to be very clear about the 3 different kinds of errors that we need, medical errors we need to be aware of. The first one is a near miss. The near miss is where we actually had an error, but it did not make it all the way to the patient. So let's say pharmacy put the wrong medication into the cubby on the dispensing machine in the unit, and you pull it up. Well, you didn't do your 3 med checks, okay? That's a problem. But when you go into the patient's room and you get ready to do that there and scan them, you notice that that's not the drug you thought you pulled out of where you looked at it. And when you go back in there, you didn't give the med. So that's a near miss. You did not give the med. You caught it. But it was still an error in how that was happening, okay? You might be able to catch that error, but somebody else the next time may not catch that error. So we need to recognize these near misses need to be addressed so that we can prevent them from happening in the future, trying to make as safe of an environment as possible. The next up is an adverse event. An adverse event is where the error actually made it to the patient. That is not what we want to happen. It's out of the ordinary. Now, they can have no reaction at all, or they can have a minor reaction that does not promote any permanent damage, harm, or death. Okay? But when you do have an error, that does result in an adverse event that does result in harm, permanent damage, or even death, that is called a sentinel event. So we have a near miss. We caught the error before it even got to the patient. An adverse event, okay, or an incident, okay, that is where it actually got given to the patient. We didn't catch it before it got to the patient. They may have some adverse effects or they may not have some adverse effects. But when they do have adverse effects and that results in permanent damage, harm, or even death, that then becomes a sentinel incident or a sentinel event. Okay? So those are the three that I need you to be able to positively be to differentiate between. So why and how does the appropriate management of errors and those adverse events help us improve patient safety? How does that happen? That's what I mean when I say that in the third objective that you are to examine the complexity and management of those errors and adverse events, improving client safety. So how do we manage that? There's a process, right? There are three specific areas, three specific departments that are involved in that. That is nursing. We also have risk management. Then we have quality improvement. Okay? All three of those departments, all three of those areas are involved in the monitoring, the reporting, the evaluation, and the educational improvement of all of these errors. Okay? We can't do it alone. It does take all three departments to get that done. They are all interrelated. So let's go through an error. Medical error says, okay, we gave a drug. Patient ended up being okay, so it's an adverse event. In other words, we gave them the drug, but there's nothing dangerous or harmful that really happened permanently. Okay, so we have an incident, an adverse incident. The nurse has to feel comfortable and safe enough to write up how the error occurred, or an incident report, right? That then gets sent to risk management. Risk management is the guy in the middle. What they do is they actually put the incident into a database that actually sorts all of that information based upon patient data, based upon what specific unit data, based upon a type of nurse, or what specific nurse, or what specific med. They can do that. They have a database that they can plug it in, and then they can pull it by whatever part of that data they would like to focus on. Okay. The other part that risk management does is, of course, it's all about what their name is, risk management. They are tasked with how to keep any liability costs to the hospital, to the facility, down. Okay? That's kind of how they came about to be. But as our culture, just culture, and our culture of support has changed, risk management has become more of a team member rather than a cover your hiney kind of thing. So that's how they're all related, because once risk management has that, and if they see something that's like trend, something that's happening frequently and it's a trend, then they can present that information to quality improvement. They do the evidence-based search on the internet, on Joanna Briggs, on GCU's library. They compile a most up-to-date policy, an education protocol based on the most current evidence, and then they promote that out. Okay? If it's not that there's a new evidence, or we're not doing it by appropriate evidence, it's that we're doing it, we're slacking off on something, or we're taking shortcuts, then quality improvement will come in and they will do a re-education, explain why the re-education was occurring, why we can't take those shortcuts, and how much harm we can actually cause. Sometimes that's the part that we become complacent about, is how much harm we actually can cause, not recognizing that those shortcuts that we do are at the root of those errors. Okay, so that's how they're all interrelated. those three groups. So now the fourth objective is talking about you being able to analyze applicable technologies and the standards of practice that promote effective, safe practice. So really, and what I want to know is, what are those technology and standards of practice that promote that? Well, one of those areas you can find that is the Nursing Guideline Clearinghouse. Another place would be the ARC, which is that academic of quality improvement, the NDNQI, which is the nursing database of nursing incidents, I believe it is. You also have, there's a variety of different things that are utilized by different organizations, but they're all working on the same improvement factor, okay? And that is utilizing technology. And technology would be vital signs machines, a cardiac monitor, electronic bed, a computerized medical health record. How about a finger stick blood glucose monitor? How about an iStat machine that gives you stat H&Hs or ABGs or even chemistry panels? Those are also technological aspects that help you promote effective, safe practice. Okay? Because some of those things, we actually can get that information much sooner now than we were. Now you can get an iStat result back in less than a minute and a half, whereas before, you send it to the lab. Well, the lab has a turnaround time of a minimum of 45 minutes, and if it's stat, they have an hour to get that back to you. I'm not sure about you, but I don't feel like an hour really meets what I consider a stat criteria. But that is what the standard run time is for some of these labs. So the new iStats and ABGs and things like that we utilize to help us have actually made things much safer and much more effective for patient care, but we also have to make sure that we maintain it, we monitor it, and we actually do them correctly for them to be correct. And that's because, you have to do the quality check the same every day, at the same time, in the same way. The cleaning has to be done the same way every time the cleaning is done. So those are where standardization helps make sure that these items stay calibrated correctly and utilized correctly so that they are effective in our patient care. Good. So the fifth objective for this safety piece is provide effective individual system strategies to reduce the risk of harm to self and others. Okay, we've actually already covered some of this. Effective individual and systemic strategies. Well, some of those are very easy if you think about it. They now have computerized medication dispensing machines in individual units. They now have that all of our medications are unit dose, patient specific, packaged, patient specific. A long time ago when I was a baby nurse, they came in huge bottles of 1,000 at a time, and we kept them in our med thing, and we used to get the big old bottle and dump how many ever I needed. If I had 12 patients and I needed 12 of these, I'd get 12 of them out. That's just not safe practice with the sheer numbers of patients that people have to take care of now, and the other kinds of medications that they take that can interact with those meds now, compared to what we had then. We had a drug book that would cover half of what the drug guide books you have these days. So yes, the more that's out there, the more safe we need to try to keep our patients. And system-wise, we have tools to help us with that. Individual-wise, that's a little more difficult. This is where I say something about, you see a lot of shortcuts out there in the practicing world that are not acceptable. You see some that are not acceptable, that done one time they're okay, the patient's safe just by the skin of their teeth. the next time they're done, the patient was not safe. Um, Taking shortcuts, you never know when your shortcut is going to be okay or when your shortcut is not going to be okay. It is preferred that you do practice the way you're taught, the way it's supposed to be done. And every hospital has policies on everything. Be aware that if you violate policy and procedure, even if that's the way everybody else on the unit does it, if you have a policy on your unit that says it's supposed to be this way, and nobody else does it that way, but you're the one that they see not doing it that way, you can be terminated on the spot for violating policy and procedure. Life is not fair, but you need to keep that in mind. So you have to make sure that you are the person that's keeping your patient safe by following all of the components of safety that you've been taught in nursing school. I don't care that they don't do that out there. We need them to do that out there. So if you go out and role model it, eventually those people that are not doing it, they're going to retire out, and the people that you are training up behind you, and you train them the right way, the way you learn, then eventually we will all be doing it the right way. But we got to do that shift in thinking, and it takes time. Sometimes it's time we don't have. We need to keep our patients safe as quickly as possible. Okay, so objective 6. I'm asking you to explain what relevant risk or risk anticipation reasoning and strategies should you as a nurse consider in the clinical setting because they're designed to help prevent failure to rescue situations. Okay, so when I say failure to rescue, that means someone did not recognize earlier stages of patient compromise or patient decompensation. Because the sooner you recognize that and the sooner you intervene on that, the better the chances of recovery are for the patient. The longer you wait, the worse they get, the higher their morbidity rate is. Okay? So failures to rescue. Yeah, if you know that you have a patient whose SATs are 84, I don't care if they have COPD or not, they need more oxygen. The only time you have to worry about a COPD patient's drive to breathe is if their SATs are 94 normally and you have them on enough oxygen that their SATs are 98, yeah, you're going to drop out their drive to breathe because their body goes, hey, we're such a good thing, we've never been this good in years. We don't have to breathe. That knocks out the drive. But when the saturations are less than 90, then you're not going to decrease their drive because they don't have enough oxygen in there for you to decrease their drive. You need to give them more. Okay? So that's part of the clinical reasoning and judgment that you need to consider. Don't just take it that, yes, we know that that happens, but if they are not having a normal saturation, then yes, you can increase the oxygen level. But if they have a normal saturation, then don't increase the oxygen level. If it's normal, they don't need any more, and yes, it will drop the drive. If it's not normal, then yes, they need the oxygen. We don't even have to worry about dropping their drive. At that point, we don't even have good oxygenation happening. So those are the kinds of things that I want you to think about when you're talking about failure to rescue. So if somebody did not recognize that decrease in level of consciousness, and now we've got a patient that's stroked and nobody recognized when they stroked, or drops in blood pressure after a surgery and nobody recognized that this patient was dehydrated from blood loss in surgery, and nobody called with a decreased urine output, and so no fluid challenges, no fluid boluses were given to compensate for that patient, and now they're in a hypovolemic state due to estimated blood loss and dehydration. That is a failure to rescue. Those are the things that we don't want to happen. So the sooner you recognize something is not right, the better chances are for your patient. Um, One of the ways that we can do that is by calling a rapid response sooner than later, right? If you have your gut instinct says something's wrong and I can't put my finger on it, call a rapid response. More eyes will help you put a new perspective on it. The other piece is if you have called a rapid response, but by the time the team gets there in less than 3 minutes, you are now doing CPR, you are too late. You should have called a code, not a rapid response. You called that way too late. That is a failure to rescue. So I hope that you have a better understanding of what we mean when we say failure to rescue. And so how do we prevent those? We actually have to anticipate what can go wrong so we can prevent it. Yes, you learned in med-surg what was right, what was normal. You also learned what abnormals there are with specific diseases and patterns. But what you learned in level 4 is, okay, now I need to start looking for urgent matters in emergent situations where I actually have to save their life. So yeah, if somebody has surgery, there is always a risk for bleeding. There's always a risk for infection. So how do we prevent that? Well, for the bleeding, we monitor for bleeding, and we monitor urine output so that we know how hydrated our bodies are, our patients' bodies are, and whether we need to give them some fluids or not. Based that urine output and the blood pressure and the heart rate, we know whether this is dehydration or if this is body response or whatever. Those 3 things can tell us that. So that's why I want you to use what you've learned this semester to help move into the prevention mode, where you have to anticipate what can go wrong and then prevent them. That's how you get to reduce harm. Okay? If you anticipate what can go wrong and have a plan, just in case, then you're going to be an awesome nurse. Okay? The 7th objective for this piece is talking about your ability to summarize the examples of adverse medical events, potential incidents, near misses, common to the clinical setting, and then also being able to do a root cause analysis. So really and truly, this number 7 is all about the near miss presentation that you did, about the patient safety labs that you did, about the root cause analysis that you did on your near miss events and stuff. That's really what number 7 is, your ability to do that, and you did it in your assignment. Okay? Moving to the next section, that is Module 13, is talking about informatics and technology. The first objective says that you are to explain how information technology combines with nursing knowledge, achieving client care decisions based on clinical reasoning. So really and truly, how is information technology paired with your nursing expertise to achieve clinical decisions with clinical reasoning? In other words, you can get a blood pressure, but if you don't know what to do with it, or if you don't know what normal is or what abnormal is, and whether it's low or whether it's high, if you don't have that education and that clinical judgment and reasoning behind it, it doesn't matter that you're getting a blood pressure. That's in its simplest form. But we can apply that to any kind of nursing knowledge, nursing decision-making, nursing reasoning. Okay? That's pretty much what that means. Well, those kinds of informatics and technology are, well, we have vital sign machines. We no longer have to do manual blood pressures every single time you try to take one. You now have a machine that'll do that for you. You also have a machine that can monitor cardiac rhythms. You have a machine that will do a continuous cardiac monitor, in non-invasive readings, arterial lines, EKG waveforms, respiratory waveforms. We have technology such as ventilators. How about hourly urometer measuring devices, hourly urine output measuring devices? We have electronic devices now that can give us an accurate mil per mil urine output per hour. So we have gotten a lot of tools to help us keep our patients safe and to help us anticipate what might be going wrong and help us intervene earlier than later. However, it goes back to, if you don't know what to do with that information, then we have not been successful in this BSN program. Because an associate degree nurse can do that. They can take a blood pressure, but they don't always know the why I'm worried about this or the why I'm worried about that. You're supposed to be as the BSN, and that is what your education level is all about. And so you do need to know the why, which is why the research says that BSN level nurses have better outcomes for patient outcomes, have better patient outcomes. Well, yeah, because you know why we do this and why we're looking for this kind of a problem. The other nurses are just kind of taking care of the patient, not really looking for anything out of the ordinary, right? Not anticipating anything. Kind of like the Lewis Blackman story that you learned about, right? The people didn't anticipate that, you know, maybe we made a drug error. Maybe we have a gastric ulcer. You know, if he's had a chest muscle surgery, why on earth would his belly be having pain? It shouldn't be. And why didn't somebody put two and two together with that? And that's all I'll say about that. That is part of why you need to be able to use that knowledge in your clinical reasoning and clinical judgment. Having those tools and those devices are only helpful if you know what to do with it. Okay? The second objective says that we would like for you to be able to examine the critical role of healthcare technology via exploration of technology-intensive learning opportunities. So some technology-intensive learning opportunities would be your training on all of the electronic devices that you're going to use at a new position, a new job. The intense electronic medical record education that you're going to get when you get your first job. The fact that you can do continuous learning, continuing education units online, rather than having to go and sit in a classroom or go and sit in a lecture or something. You can actually do it self-paced online. That is also an intense technological learning event. Okay? So having the ability to learn things at a much faster rate, a just-in-time education, and at our own pace has been just an excellent contribution to nursing. Okay. Number 3 says you need to be able to correlate the use of appropriate healthcare technologies with improved critical thinking and clinical proficiency. Well, one of those would be where you're looking at the documentation and you see nurses who are copying and pasting the prior nurse's information and pasting that as their assessment. Is that safe? No. Should it be that the nurse's first assessment is their own and they can copy and paste themselves if there's no change in practice? Yes. But are you supposed to copy and paste someone else's assessment and take that as your own? No. No. And so being able to use the technology and apply it in a proper format actually can improve patient outcomes. But if we don't do it correctly, we can harm patients. And that's really all that means. That's really all that means. Actually, having electronic medical records has improved patient outcomes because we've actually decreased documentation errors. We've decreased medication timing errors. We've decreased communication errors based on the fact that we couldn't read each other's writings. So lots of things have come around based on this technology, but we have to continue to use it correct or it will not be able to help us do it correctly either. The fourth objective is model the application of relevant healthcare technology to improve client outcomes. So we've actually given those examples already. Some of that was We have an incident, we do a report, we get that down to risk management, they have a database, they look at trends, how often does it happen, is it related to this particular med, to this particular nurse, to this particular pharmacy tech, to this particular time of day, and then they get information to the quality improvement, they do the research, and then they get the education out there. So those are some examples, okay? But again, it goes back to, I can have that urometer that gives me an hourly electronic reading, milliliter per milliliter of urine output. But if I don't know why I need to know it, or if I don't know what the parameters are that I need to know for it to matter to me, then it's not going to be, it's a waste of time for it to be there, right? And that's really what that means. Those are some of the applications that examples where you use technology to improve patient outcomes, but you got to know what to do with it. Objective 5 is for asking for you to demonstrate the need to protect privacy, confidential regarding client health information, electronic medical records, and other data documentation systems. Well, the biggest thing is we're talking about HIPAA here. Why is it important that we monitor for HIPAA, or that we are concerned about HIPAA? And then how might that relate to the medical record? Well, electronic medical records are gullible or fallible if someone logs in and then walks away with their login still there. Someone else can log in, or actually somebody else can just start typing away and maybe do some bad things on somebody else's name, official logged in name. So never leave a computer logged in or not locked so that someone else can gain access to your ability to document. Okay? You never want to do that. Because the other piece is that is also a way that private information is stolen. Identity theft happens, also medical insurance theft. It's kind of interesting when somebody gets a phone call and says, we're going to garnish your wages because you have not paid a single penny on your cosmetic surgery for your breast augmentation that you had. And the person goes, what breast augmentation? And they find out it was a roommate that they kicked out of their apartment 2 years ago, took that information and went and got breast job done in retaliation for being kicked out of the apartment. Wow. Isn't that kind of scary? Yes. So we need to protect that information. We need to protect that information. All right? Even printing the information has to be done cautiously. So let's say that you work on the 3rd floor all the time. So your login is set to print on the 3rd floor printer. Okay? But you actually get pulled to the 4th floor to work for the day. And you don't recognize that you have to change your printer code. So you print something that you need to put on the patient's chart, but it doesn't print on the 4th floor's printer. It printed on the printer on the 3rd floor where yours is set up to go. Is that a HIPAA violation? Absolutely. It should not be on that floor. Nobody on that floor should have access to that. Absolutely. That is a HIPAA. So it's easy for HIPAAs to happen. So we need to be diligent about that. Okay? Moving to Module 14, we're going to talk about quality improvement and system-based practice. This one is actually very quick and very brief. So what is the nurse's role and the nurse's approach to improving client care processes and patient outcomes? So what's your role and your approach in improving patient care and patient outcomes? Well, that is your job. Your entire job is all about improving patient care and patient outcomes. Advocating for the patient, having them participate in their care, taking ownership of their care, moving into a prevention world rather than a reactive world. That is the entire job description of an RN. So everything that we do is related to improving these patient outcomes. Okay? The second objective says you need to be able to summarize quality improvement as an essential component to nursing practice regardless of the healthcare environment. So, in other words, why is quality improvement an important component of nurses no matter what healthcare environment? No matter if it's long-term care, rehabilitation, um, uh, cancer unit, be that an assisted living component, no matter where this clinic, no matter where this is occurring, we still have to recognize that we are humans and we are not perfect, and there is always room for quality improvement. And that's why it's important, is because we need to make sure that we are always striving to be the best that we can be and provide the patients with the best that we can provide them and get them to the best health that we can get them to. Okay? The third objective says for you to explain the value both individuals and teams contribute to improvement in client care processes and outcomes. Well, this is where you have to be able to tell me the difference between teamwork and collaboration, and whether it's an individual looking to work something or a team working something. So I will tell you, if one individual is working on something, it's not going to go along to improvement very fast. As a team, you can all be working on something if you collaborate. So collaboration is where you are all working towards the same goal. You don't all have to agree with it, but you all are working on the same goal. So that might be, you know, you're supposed to be looking for information on a specific type of illness, and you're going to do an education piece on that. Well, okay. But if it's something that is an education piece that impacts just your floor, your unit specifically, and something that your nurses are dealing with every day, then you're going to have a little bit more passion about it. There's going to be a little more concern about it. There's going to be more of you who are focused at making a difference at the end. So that's true teamwork rather than just collaboration, working towards a common goal. Teamwork is there's the passion driving you towards the same outcome, same goal. So doing things on an individual basis are much slower than if you do them on a team basis, but it takes both individuals and teams to make a true impact on patient outcomes. Okay? So the fourth one says that you are to be able to investigate quality improvement initiatives in the spectrum of healthcare settings and organizations. Okay. So what might be some of the quality improvement initiatives that you have heard about in some of the places that you've been as a student? One of those might be SCIP. You actually have learned them in the your program here as standards of practice. But out in the practice world, they were not standard of practice. They were actually come upon after our schooling was finished. So they were implemented as core measures. These are the measures that need to be reached consistently every time. Well, that's what a standard practice is. So standards of practice, what you call standard practice, is actually what you will hear called as a core measure out in the practicing world. One of those is the SCIP protocol, right, for the timeouts and removing Foley's, prevention of infection after surgical interventions, being aseptic care when you take care of central lines of any kind, such as a PICC line or a central venous catheter in the subclavian line. Those are core measures. Those are standards of practice. Those are the different kinds of quality improvement initiatives that have actually made a difference in patient outcomes over the years. Okay? So now, Objective 5 says, appraise the quality of client care in healthcare institutions based on site-appropriate criteria. So what you need to know is, what does site-appropriate criteria refer to? And why is facility appraisal necessary? Okay. So if you are saying something about site-appropriate criteria, it is like specialty hospitals. Um, if you are an OB hospital for labor and delivery, and that's all you do not want a cardiac patient coming into your facility because that is not within your scope. Your nurses are not up to date and ready to care for that kind of a patient. But yet they don't want labor and delivery at the cardiac hospital. So diversification has to be done uh, safely, uh, but we still have to care for populations, which is why emergency rooms have to be able to prepare for anything, and they have to stabilize a patient before they can transport them to a specialized facility. And then, of course, before they can be transferred, the physician um, in the ER has to have had given report to a physician at the receiving facility, and they have to have said, yes, I will take this patient. Then they can arrange transportation to that facility. So there's a lot of steps to this, and it's one of the things is hospitals have to do something called healthy grades. I hope you guys remember talking about that in the past, where they actually report how many errors they've had, how many incidents, wrong way surgeries, wrong surgical sites, those kinds of things. What are their patient satisfaction scores? Those things have to be published according to the accrediting bodies these days. And that is how they're getting reimbursed. And that is what we mean when we say appropriate criteria and site appropriate criteria. Okay? The facility is appraised based on what they claim is their specialty. Okay? The sixth objective is asking you to explore the concepts of patient care delivery models. So some of those different care models would be what you see now in like acute care facilities. You see RNs, only RNs, in hospitals taking care of patients, right? In the past, we've actually had team nursing where we had an RN, an LPN, and a couple of CNAs be part of a team, and they actually took care of a group of patients. The RN did all the IVs and all the IV medications. The LPN did all the oral and the IM and rectal medications, and the CNAs did the bathing and the water and the linen changes, and then everybody helped each other out, answering the call lights and doing the turning and things like that. That is called team nursing. But what you see is just RNs, and that is primary nursing. The RN is the primary nurse, and it's always an RN taking care of them. You get to a long-term care facility, and they have an LPN that's actually on the floor, running the floor, but yet there's a director of nursing that is an RN who is accountable for that LPN's practice. So, I don't know that I would want to go to bed and have somebody else practice and me be accountable for it. I don't know. That's something I'm still trying to determine how they work that. That's not my area of expertise, but it is out there. So different care models are out there. Okay. This last one for this piece says you need to be able to investigate the role of the RN related to bringing issues of concern at the work unit level to the attention of those who can facilitate a resolution. Kind of sounds like an incident report, doesn't it? Or the fact that you can stress your concerns or mention your issues that you've seen and not fear retaliation or retribution. That's a healthy work environment. Because really and truly, you're only wanting the best to happen for the unit, for your colleagues, and for your patients. But you can't do that if you feel like you can't speak up, or you will be the next person who gets a poor outcome on your eval and you won't get your raise, or you get written up because somebody had to find something to put you in your place. Those kinds of things, they're really not acceptable. And we do need nurses to be able to investigate and to act on things within their abilities without fear of retaliation. Great. Module 15 is the last module for Exam 4 content review. And pretty much we're talking about the different roles of RNs and the models of RNs. And one of the ones that we really haven't talked a lot about that we focused mostly in this